Hello and good afternoon, everyone. My name is Lim Heng Li alias Henry Lim, and I'm a third year medical student from UBD. I'll be presenting my study on a retrospective analysis on the refractive errors of children seen in one of the district hospitals in Brunei, the Seri Seri Begawan Hospital. So before I start, here are the table of contents for this presentation. And first off, I'll be defining the terms used in this presentation. So what are refractive errors? Well, the National Eye Institute defined refractive errors as a problem with light not focusing accurately on the retina due to the eye and or the cornea shape, which will eventually lead to blurriness in vision. And we term the children according to the definition from UNESCO, where basically children are every human being below the age of 18 years. So who can be affected by refractive error? Well, it can affect everyone, regardless of their age, their statuses, or their ethnicity. And the refractive errors covered are shown here, with more emphasis on myopia as it's more directly affected by COVID-19. So why do we need to conduct this study? Is it important? Well, yes, it is, due to the number of consequences that uncorrected refractive error can bring. Firstly, it can cause a decreased vision-related quality of life, which may negatively affect the economy of a country. Secondly, for children, it can negatively affect their education, their social skills, and overall the general quality of life. And as children do not usually complain about the blurriness of vision, this may result in low educational achievement and may cause a burden to both the children and the parents as well. It's also estimated that by 2050, 5 billion of the world will be myopic, with 1 billion of them being high myopes. And this, as the severity of myopia increases, it can impose certain diseases such as glaucoma. And finally, COVID-19 also has a role in refractive errors, which will be explained later in depth. So here are the aims and objectives of the study. The aim is to assess the prevalence and the different types of refractive errors of children seen. And the objectives are to describe the demographic profiles of the children, to determine the different types of refractive errors and the severity, and also to associate both of them together. So moving on to methods, I'll be explaining the study design and procedure. So during late last year, October last year, approval for this project was approved by the ethics committee in UBD, and data was extracted by the clinical supervisor in November through the clinical database of Brunei called BRUHIMS. The clinical supervisor also acted as the gatekeeper, and it's important to note that all subjects were de-identified prior to analysis. And the data collected contained variables such as age, gender, ethnicity, family history of glasses, and also refractive errors of both eyes of the patient. And initially, there were 450 patients, but this was reduced to 403 patients after following these two inclusion criteria. And eventually, data was entered into Microsoft Excel and analyzed in RStudio. And in the RStudio, there's 3 statistical tests that was conducted. The chi-square test, which is to check for any significant difference between at least one pair of demographic factor groups with a refractive error. And if the assumptions for this was not met, then the Fisher's exact test was conducted. Multiple logistic regression was also tested to find out to assess the odds ratio, to see which group is at more risk, and to check for any associations between demographic factors within refractive errors, which will be explained more later when I present the results. So here is this slide basically shows the definition of refractive errors. So all the absolute refractive errors were converted into spherical equivalence refraction to be made and to be diagnosed by a calculator, which was obtained by permission after it was given by Tello and Gravis. And basically, this table here shows all of shows how the diagnosis was made. And the diagnosis was basically made based on both eyes of the individual. The severity, on the other hand, was actually diagnosed manually, and all of these definitions come from literature. And to figure out whether we should use one eye or both eyes of the patient, we did something called an intra-class correlation coefficient, where basically, if that value was close to 1, it means a strong correlation, and hence the average spherical equivalence of both eyes could be used. And in this study, we found a value of 0.79, indicating good correlation, and hence the average was used. So now moving on to the results of objective 1, which is to describe demographic profiles of children. And there's four different variables, as mentioned earlier. So for starting with age, there's primary and secondary ages, which are split into 2 groups here. And you can see that there's a higher prevalence in the secondary age group, with the mean age of the children being 11.8 years old. In terms of gender, there's more females compared to males. And the most prevalent ethnicity was Malay, followed by Chinese and others, which include Indian, Iban, etc. And in terms of family history of glasses, a majority of the patients actually presented with family history of glasses. So this table and chart basically shows the prevalence of refractive errors seen in the study. And as you can see, myopia is most prevalent by quite a large amount, followed by hypermetropia, then emmetropia, and finally mixed astigmatism. Now moving on to objective 3, which is to associate the risk factor and refractive errors. So as you can see, this table basically shows the results of the chi-square test, and you can see that for age in all 3 refractive errors, there's p-value of less than 0.05, which in this study indicates statistical significance. So there's a significant difference between the age groups, The rest are not significant except for family history of glasses, where in hypermetropia it is significantly different. And to figure out which group was at higher risk, we did the multiple logistic regression test. And for myopic patients, as they grew older, they had high risk of having myopia. However, for hypermetropia and astigmatism, it was the opposite. So if they grew older, they had a lower risk. And for family history group in hypermetropia, if you had no family history, you had high risk of having hypermetropia. So in order to talk about the myopia in general, being older actually has shown that you have a greater myopia risk if you are. And there's a strong association between myopia and education, where basically as you age, the educational demand increases and hence your myopia risk also increases. So this just to explain more on the effect of COVID-19 on myopia. So first off, we have to introduce that a study conducted in Brunei in 2014, which was done on the same clinic, actually found that there were 46.9% of the population were myopic astigmatism. And you might expect this number to remain the same over the years. However, it actually increased by 20%. And in this study, you can see that the value of myopia was actually, the prevalence is actually 68.7%. So why is this so? Well, this could be due to the effect of COVID-19, specifically quarantine myopia, which can be further explained in three parts. The first part being that over 1.1 billion children in the world has actually increased digital exposure due to online learning. And there's a positive association between myopia and 1 additional hour of digital device use. And hence you can see the consequences there. And basically due to home quarantine measures, children have been forced to stay indoors, and time spent outdoors is actually a protective factor against myopia development and progression. And hence without spending time outdoors, the protective factor is not there. And lastly, near work is also associated with COVID-19, and the studies have shown that children actually prefer to study on smartphones as it's more affordable than laptops. And hence, there's actually an increased time spent on near-viewing devices, causing a higher risk of myopia. Severity of myopia, just in brief, can be seen here. Basically, there's a high prevalence of low myopia, then moderate myopia, and high myopia. And there's significant associations between demographic factors found in age and ethnicity, and family history of glasses and ethnicity in no myopia, and also age family history in moderate myopia. And just to explain about the family history and ethnicity, one study found that myopia development is actually believed to be influenced by genetic and environmental variables, and hence COVID-19 may actually play a part in myopia development, specifically the environmental variable part. Here, the strengths and limitation of the study. Basically, the strength is that only one other study has been conducted in Brunei, and the limitation is that the main limitation is that only urgent cases were allowed to attend the hospital in 2020 and during this period, and basically the overall prevalence might not be a true reflection that year. In conclusion, myopia is most prevalent refractive error in this study, and it showed that there's a 20% increase in myopia over a decade in quadrilateral, which may be attributable to the COVID-19 pandemic. And it's hoped that this study, the results of this study and the findings will be able to help other studies by aiding them and also to fill any gaps of knowledge present. So here are my references, and thank you for listening.